So thank you to the audience. Stay tuned in because we are now going to start our course on measuring, marking, and managing astigmatism in cataract surgery. All you need to know.
Leave it if you can't.
So I'd like to invite the co-instructors on the main dais here. Dr. Shugatopal, Dr. Sagar Bhargav, myself, Dr. Swati Agarwal, Dr. Ajay Paul, Dr. Vishali Vasavada, and Dr. Arup Bhaumik. So let me ask you, how many of us are doing Toric here? Can I have a show of hands? Okay, great. So I believe that once you're leaving the hall, everyone would be well versed with all the nitty-gritties and all you need to know about managing astigmatism. And it's like a once in a lifetime opportunity for the patient to see that clear, because giving the toric IOL close to the nodal point of the eye enhances the quality of vision beyond doubt. And our next instructor, Dr. Shugatopal, the Chairman Scientific Committee of Ophthalmic Society of West Bengal, he's going to stress on the facts about the need for toric, the patient selection, and the preoperative workup. Sir, over to you.
Thank you, Dr. Agarwal, for including me in this prestigious IC. Good morning to you all. It's just good afternoon. So I'll be speaking on need for toric mainly, and patient selection, and what sort of preoperative workup should we do. So cataract surgery in present day is no longer a cataract surgery. It has become a phacorefractive surgery, where we not only take out the cataract to clear the optical media, but also correct whatever myopia, hypermetropia, astigmatism, and presbyopia is there. We try to address them. And astigmatism, as you see, is one of the important factors. So what is astigmatism? There are basically mainly two types of astigmatism we look at. It's with the rule astigmatism and against the rule astigmatism, and also there is oblique astigmatism. So with the rule astigmatism, they have, sorry, you have pointer. They have the steeper axis at 90 degree and is present mainly in younger patients and myopic eyes. So when we are born, we are obeying the rule, so with the rule, and when we grow older, we start disobeying the rule, so we are against the rule. So older people mainly have against the rule astigmatism, where the steeper axis is at 180 degree. And this is basically a representation in the topography, where the warmer color orientation gives whether it's with the rule or against the rule or oblique astigmatism. Now, there are problems with astigmatism. They can cause blurring of vision, distorted vision, eye strain, headache, discomfort, and whatnot. So if we get the scope of correcting that, why not? And if you see this picture, this is a patient where a schematic diagram where a patient has astigmatism and cataract, where the cataract, if the cataract is corrected, his vision is improving, but the clarity is not. And if an IOL with toric IOL is put, you can address both the factors, patient getting pristine clear vision. So it has been shown that with visual outcome with toric IOL results in better visual acuity, less post-op refractive astigmatism, higher rating for clarity of vision, greater spectacle independence for distance, and also for near if you are doing multifocal toric, and also high post-surgery patient satisfaction. But still, the number of patients having toric in our practices are not great, because possibly because of some myths, such as like very few patients require toric IOL, some surgeon things. Then some things that patient are not asking for toric, so why we are giving toric to them. Then some patient think it's costly affair, And some doctors think that astigmatism, any astigmatism can be corrected with incision by making incision larger. But the reality is different. Is possibly is avoidance on our part that we are not offering the patient the choice of surgery which they should have. And as a result, patients are not counseled for toric in many centers, and probably we are apprehensive that we might lose the patient if we offer them a higher package. The patient might just run away to a different center and get the cataract operation done. And surgeons in the initial period are quite often not sure about their postoperative results with toric, and all these actually result in patient not being counseled and not many toric patients in the surgical list. Now, if we look at the prevalence of astigmatism, we will see by Warren Hill about 6,000 patients, we will see about 40 to 45% of the patients are over 0.75 to, in fact 50% of the patients over 0.75 diopter of astigmatism. And also in this Chinese study of large volume of patient, almost 40% of the patient or 48% of the patient again had astigmatism more than 1 diopter. So these are the patient who could have been offered toric IOL. So if we select the patient, we'll obviously has to choose this patient, any patient corneal astigmatism over 1 diopter cylinder, but we have to ensure that the patient had proper counseling, and we have to ensure that the astigmatism are regular astigmatism, not irregular astigmatism. Irregular astigmatism patient, which can happen in say in pterygium, in Dallin, in other condition like even corneal foreign bodies, are not good patients for toric IOL. Also, very high myopic patients, chance of postoperative rotation is higher, macular pathology if not stable, and type A personality. Some doctors tend to avoid these patients. What preoperative assessment should we do? I think all patients should be assessed for toric IOLs. So preoperative assessment shouldn't be different in any patient. So what we normally do should be done. But important thing, because it's a premium IOL, we have to make sure we have to observe for dry eye and the corneal surface. Any meibomian gland dysfunction should be treated. Any corneal surface irregularities should be treated. This patient, if he has a biometry done, will it be accurate? Never. So we have to make sure, we have to ensure this is treated first, then we are addressing the patient's cataract. So these are the things which we have to take care of. And quite often the patient come to us after being seen by the optometrist on the same day, dilatation drops, IOP being checked, and in those situations, if we advise cataract surgery workup, they can end up with wrong biometry because the surface is already having some distortion. So they have to be checked again if required. Third thing, for any premium IOL, in fact for any IOL nowadays, we need to do an OCT, because though however good we are clinically, sometimes we do miss subtle retinal changes which can end up with unhappy patients like this. This patient is very difficult, lamellar hole, very difficult to pick up because there is not that much of irregularity or ERM as well, and we might miss them. Or early ERM or vitreous traction, retinal traction. So these are the patients which we can miss. So OCT, pre-op OCT in this patient is helpful. In fact, we should do for each and every patient's going cataract operation. Biometry, Dr. Varga will take up, so I'll not speak much, but ultrasound biometry in my practice is a big no-no. In case of hypermature cataract where we cannot get optical biometry, better is to go for immersion biometry. And optical biometry is the investigation of choice for biometry. Keratometry, I do try to match the auto K with optical biometry and repeat if they don't match. And if there is a difference in the refractive cylinder and the biometry cylinder for more than 1 diopter, probably it is worthwhile to see in the pentacam why the difference is. And the next thing, again, Sagar will be taking up in details, posterior corneal curvature. Any surgeon doing cataract for toric IOL should have some idea about posterior corneal curvature, which is vertically steep posteriorly, and it causes overcorrection with the rule astigmatism and undercorrection with against the rule astigmatism. So we have to plan it accordingly. But with the availability of the Barrett toric formula, which presumes some amount of posterior corneal curvature, or AOL master or pentagram which can measure, that bit is nowadays well taken care of. And also a surgeon pre-operatively should know his or her SIA, because SIA varies with incision location, incision width, incision length. You have to know your SIA, and there is siacalculator.com where you can put your data to know the SIA, because whenever you are doing a toric calculation, you have to put your SIA there. You can just cannot guess at 0.5 or 1 or 0.1 and put it there. So it's better to know your SIA at different position of incision. Thank you so much.
Thank you, Dr. Sugatopal. That was beautifully covered topic with all the facets of the need for toric and the patient selection. So I'd like to ask, what should be a cutoff for toric? Dr. Vishali, what is your cutoff for a toric IOL?
So I think the cutoff, it probably changes whether you are starting or whether you have already had enough experience. I think if you are just starting off or you have just done a few early cases, cutoff should be at least one diopter total. That means measured and combination of induced. But as we do, let's say 10-15 cases, and once you are confident of your results, it can go down to as low as 0.5, depending on which brand IOL you are using and what is the lowest correction that they offer. So for me, for example, it would be anything more than 0.5. Sir, anybody else?
Yeah, with the rule, probably I'm a bit lenient, but if it's against the rule, it's 0.75 for me, for toric IOLs, and for any multifocal or trifocal toric, it can be as low as 0.5. And with the availability, even with the Femto, my cutoff also remains the same. It's a bit more, one diopter, maybe 0.75 for trifocals, and for these normal lenses is 1 diopter. If I am doing a Femto LRI in them.
So with the rule you can still let go
So
of it. But
in my case, generally, my cutoff is 1. If the patient have no cylinder in other eye, then my cutoff is less. Then maybe 0.75, maybe 0.5. But if other eye operated earlier and patient has a plano vision, and one eye I got the 0.5 cylinder, then my target to reduce that cylinder also. But if generally, if other eye has a 0.1 cylinder, 1 cylinder in other eye, which is operated earlier, I get okay, then I operate monofocal, normal monofocal lens, other eye, without implanting toric. But if toric, other eye toric is corrected, be careful for the second eye, you have to correct toric, even in low astigmatism. Otherwise, patient will be unhappy. And in multifocal, you have to correct toricity even in 0.5, 0.6.
Especially trifocals, they are very non.
I have a quick question to Arup and Ajay, who are expert in this field. There are a group of patients who have against the rule astigmatism, say about 1 diopter or 1.25 diopter, and they are not wearing glasses. So basically, they are using the toricity to do the reading. So would you implant toric IOL in those patients?
No, other eye is very important. You know, both eye the same cylinder. I don't mind keep 1 cylinder in both eye. I don't mind. But if other eye is corrected by somewhere else for surgery, then I have to correct the second eye. But if I am doing the first eye, I will not implant toric in case of my 1 cylinder, even in it.
Okay, another important thing I would like to add here is consider the profession of the patient. So like I had a patient who's a diamond merchant, but he was myopic and has an AC depth of 5.5, which was like against all odds. But still, I went in for the CTR during the surgery to take care of the bag, and I went for the toric IOL, explaining the patients, because post-operatively the patient needs good crisp vision. He cannot wear cylinder, magnifying lenses and all. He needs good crisp vision. So you have to explain to the patient, understand the personality of the patient, and also the profession of the patient is what I feel.
And also counsel about taking them back to the theatre
Yeah.
if required.
Correct. So I think both of these were excellent points. One is the second eye status. So particularly, like Sir said, in fact, I feel that if a previously operated, especially somewhere else, has a residual cylinder, and this time I can correct that cylinder and give them good binocular distance vision, that will be a good point for me, a scoring point for a patient. So yeah, the second eye status, and like Dr. Swati rightly said, what the patient wants. Unfortunately, at least for me, let's say there is a 0.75 or 1 against the rule. I don't always end up post-operatively only with that. Sometimes, most times we will end up with some spherical error, and that cannot give complete freedom. So you are left neither here nor there. So it really depends on if the patient wants at least one good vision, then it would be a toric.
Okay. So, yeah. Yes, a short question, please.
One eye is normal, the other eye postoperative. If surgically induced astigmatism is there, astigmatism of 1.5 is there after scleral buckle, and previously it was a normal. So would you recommend toric IOL?
Yes, why not? Yes.
After scleral buckle, it's
Yeah, if the retina is stable and there is no other pathology, and then definitely give the patient the best vision you
And
can
buccal
give
will
at
stay
that
there.
point of time.
Buccal
stay
you are
there,
not going to
so
remove.
Astigmatism will persist. So it is better to implant toric IOL.
Okay, so with this, we proceed to our next talk by none other than Dr. Sagar Bhargav, who has a knack of, understanding the nitty-gritties of all the instruments he gets hand at. And today he's going to discuss with us biometry, posterior corneal astigmatism, and integrated K readings in toric IOL calculation. Over to you, Dr. Sagar.
Thank you, Dr. Swati, and thank you for inviting me for this course. And so I'm going to be speaking about biometry, PCA, and integrated K. So whenever you have a patient with astigmatism where you think that this patient is a candidate for toric IOL, these are the questions that you should ask yourself, is that whether your magnitude and axis of astigmatism that you have measured is correct. Is it a regular astigmatism? Is the astigmatism consistent? And does it match with your refractive astigmatism? So when you are going to start the measurement, make sure that you have seen the refractive astigmatism and what was the BC of the patient before actually the cataract onset. So if you can get hold of the old papers, that information you get it from there. Avoid any drops. So in our scenario, once the optometrist identifies there is a cataract, the patient straight away goes for the measurements. There is no AT check, there is no parakin application, there is no tropicamide application. It straight away goes for the measurements. Get both the eyes checked because you need to understand the symmetry between the two eyes and get the measurements preferably in undilated state. So we have all these equipments available to us for measurement, right from manual K, auto K, Placido based tomography, then you have this Schamfleck based imaging, and nowadays all the biometers are coming up with the topography themselves. And so the first question is the magnitude and axis of astigmatism correct? So the dilemma in our mind when we are starting a toric practice is this okay? Is the instrument that I have taken is okay or not? So we did a very small study where we checked all these standard equipments on normal optometrists, virgin eyes, not touched. And you can see from yourself the highlighted readings are quite different in about 4 out of 19 eyes. So much variability can happen in a normal population. Imagine the patients who are coming to you for toric. And you look at the magnitude of astigmatism can vary from 2.25 to 1.6 in this example, from 0.5 to 1.75. Even the axis, see this example, 117, 95, so much of variability in axis. So what do you take from this data? Basically, whatever the cases that come to you, out of 100, 10 to 20% will have significant variation across different devices. The idea is that you should get 2 devices or 3 devices showing consistent values. That's where you will get the thing. So best is to have this, but if you still get variable readings, best is not to do the measurement at that point, identify the cause or treat it with lubricants and wait for the consistent reading to come. And if it still doesn't come and they are very close by, you go in for what is called as a median reading. We will we'll see that. Next is whether the astigmatism is regular or not. Now if we all have biometers, we all have this validation checklist available in the biometers. A little older version of Lenstan and IOLmaster tells you that if you have an astigmatism of more than 3.5 or 4.25, you should do a topography. Well, that cutoff now has come down with the present understanding. So topography and tomography is something that one has to think about, and the importance of this can be gauged by the fact that most of the biometers now come up with this Placido-based topography inbuilt, be it this Aladdin or Tommy or this iStar. Most of them will have it, or you had this topographers, now they are coming with the biometry. So essentially this combination has happened, and basically what you need to look at is the pattern of the that comes on the sagittal curvature map. So this is the best pattern that one can expect, and you will get a very good result if you have this kind of a pattern. But these are the patterns where the predictability will be not as good as what you would like to get, and this of course is a total no. This is totally irregular astigmatism. Now what do I mean when I say the astigmatism should be consistent? Now have a look at this reading. So it's showing me a IOL master value astigmatism around 2.37, and tells me that I need to put a 14.77 IOL. Now I subjected this patient to a topography on another day. Now look at the topography. The topography says just 0.5 astigmatism. We repeated the biometry on the same day, and now it tells me that it's only 0.75. So this is what I mean, that the astigmatism should be consistent. So this was probably a dry spot that was picked on that day. That became all right when we repeated the reading. So now the next thing is whether it matches to your clinical astigmatism or the refractive astigmatism. Have a look at this example, 2.63 at 95, but the patient refractive astigmatism was only -1. So how a -1 spectacle astigmatism gives me a 2.63 on the biometry? So this is the question one has to ask themselves. So when I checked the clinical picture of this patient had recovered from an adenoviral keratoconjunctivitis. So when the IOL master measured, it possibly picked up these points and gave me an astigmatism of 2.63. When we repeated the topography, the astigmatism was only 0.8. So these subtle things that you need to understand. Another interesting example, this was a myope, never worn any astigmatism correction in his life. And when he came to me, my optometrist gave me a flash value of -5.25 cylinder. But patient mind has never worn and the keratometry also gave me a 0.4.5. Now, will you put a toric IOL in this patient or not? Now, we investigated this patient. Now, what has happened is there is a refraction, keratometry and retinoscopy mismatch. Now, you go in a little more details, do a topography, and what you see is a hot spot in the superior part. Now, this hot spot was not good enough for it to produce a spectacle cylinder, but good enough for the keratometry machines to pick up the value. So that's where it gave me a 3.8 cylinder. It was basically a contact lens induced scarring because the patient was a chronic contact lens user. So this point one has to be very clear about that. What are we treating? Formula for toric IOL, right now the two best formulas are Kane and Barrett. We are all aware of Barrett, but one can also do Kane. Barrett gives me a very interesting feature called as integrated K, wherein I can put different measurements from different machines, and it will give me the K which it calculates from this, and then it will give me the IOL power. Now just look at this, it tells me to put a ZCT 700, I will get a residual astigmatism of 0.28 at 90 degrees. How many of you will accept this? So it tells me that the residual astigmatism will be against the rule. Now the basic principle in this is that whenever you aim, you should aim for a with the rule residual astigmatism. So instead of ZCT 700, I will go for ZCT 800, which will give me a with the rule residual astigmatism. This point should be remembered. Why? Because we will have a drift over a period of time from with the rule to against the rule. So if you are starting with against the rule, it will further increase as you go along. Posterior corneal astigmatism, the whole game changed after 2012 because Dr. Koch gave this concept. Now all the modern formulas come with the idea that you will have a 0.3 against the rule astigmatism added onto the existing corneal cylinder, and the posterior corneal astigmatism will not have an effect on the axis. Now this is just an assumption. In about 15% of the cases it may not hold true. The PCA may be actually more than 0.5, and the difference in axis can be more than 5%. Now I'll just skip this, and how do you know that whether there is such difference, that is the magnitude is more than 0.5? Then this is something called as a total corneal refractive power, which you can get it from Pentacam. So this basically takes the value from both anterior and posterior, and it tells me that how much is the difference between the two things. So if it is 0.3, then you are more or less all right, but if it is more than 0.5, then you need to worry. And the difference in the axis. So the axis, the posterior corneal curvature has an effect on the anterior corneal curvature in totality. So if the axis difference is more than 10 degrees, it's significant. Probably you will have to use this axis for the thing. So I'll just wind up in another 1 minute. So this is the Toric calculator which can use TCRP values to do the calculation for you. And just to winding up with an example, how do you use all this together? So this was a patient who has astigmatism of 2.46, sleep axis at 167. This is Aladdin. We did a pentacam, so you can see that pentacam SIMK is 2.4 with 167. TCRP gives me 2.5 and 171. So the difference was only 0.1. The difference was only 0.1. That means the posterior colonnade astigmatism has not produced so much effect on the overall thing. So the axis difference was only 4. So this is a very ideal scenario. What you will get. Varian of course gave me a cylinder of 3. So you have 3 different readings like this. You make use of the integrated K in this, and then 7 is Toric calculator, and this is what we get from both the things. You get a T7, residual is coming around 0.58 and 0.44. But imagine if the PCA would have been more than 0.5, this T6 will become T5. So this is basically for that 10 to 15% of patients, 80% of your Toric will work with the anterior astigmatism, but for the 10-15% where you are aiming for that accuracy, you will need that input from the thing. This was the post-op result. Patient did well, and with the same concept, the IOL master has come up with this what is called as total keratometry, which involves both anterior and posterior, and gives you the axis as well as the total power. With that, I just like to sum up that you basically need to measure with at least 2 or 3 instruments, and that should match. Integrated K is a very good tool. Please start using it. And PCA is an evolving concept, and definitely it may benefit the outliers. May not work out it for all your cases, but outliers it will benefit. Thank you.
Thank you, Dr. Bhargav. That was excellently covered. So we have multiple take-home points here. First, to treat any dry eye and ask the patient to come back, and when the dry eye has been treated, then we have to go for multiple readings if there is an inconsistency. And if even if on repeat testings you find that inconsistency staying over, then do integrate your K readings on the various softwares present online, free of cost. So do not hesitate to do that. And that was indeed very wonderfully covered. So do I have any further questions here?
Yeah, I have a question. See, like we got initiated into this Toric lenses maybe 12 or 15 years back. We didn't have all these things. All our measurements were by the autoref and then the manual. And a lot of patients say 2, 2.5, 3 we are getting, we jumped into it. We said that this is the ideal patient, I'll reduce your astigmatism, blah, blah, blah. And then we ended up again, sir, hum fir chashma pehen rahe hain, abhi bhi 1.5. Now, we didn't know all those things. Now we have all these gadgets. I can say, I can look at this. Now for non-initiated, I think a lot of people are there who do not have those gadgets. Now, as a person who has only 2-3 basic instruments, so what are the red flag you'll have that don't put here, and how much it promises?
I think the slit lamp examination, rule out any corneal scars. Autoref, manual K, they should match preferably, and the difference between the axis should not go beyond 10 degrees, because 10 degree error in the placement of IOL will reduce your effectivity by 1/3 of the corneal cylinder. So 10 degree mismatch, it's fine, but beyond 10 degrees you should do a topography. I think topography is easily available. Most of the biometers now have topography. So it's a very good idea to do a topography and see the map, because most of your problems will get solved in the map.
Absolutely, that's what
And 80, I would say you will hit 6x6 and 6x9 in 75 to 80% of patients without too much of an effort. Just by the clinical evaluation, refractive astigmatism, and the matching of the axes. Matching is very important. One point if you can take, that don't rely on single reading, because that reading can be inconsistent, and if it is not matching with the refractive cylinder. Yes, sir.
I just continuation of Dr. Roger Paul's question. The 6-7 years back, Dr. Kevin Miller came to our place, and he implanted Toric oil and asked him what is the result. He told us the 60%, 50% I hits the bullseye, and another 20% in 0.75, and rest beyond that. So you don't have to have all the instrument in a one time to start a Toric practice.
Absolutely.
You just do a good keratometry, retinoscopy with the good they can identify the axis. Yes, slit line examination, good keratometry, and autorev. You can start. But yes, sometimes in 10% cases you may not achieve the good result, but you can start toric practice. You can give good result to at least your 90% of patient. And you don't need to have a Varion, Callisto, all the, okay. If you have this is good. But even then, you can have a very good result in toric.
Thank you.
If I can just add something, maybe for us, I mean, that's what I've started doing. Look at the quality of whatever scan that you are doing. So everybody has an optical biometer.
Yeah.
Just looking at those Myers or even the reflective points, if they are good, and then you know that you've got a good reading. So you may not have more than 2 machines, but if they are doing it, so looking at this raw data, I think.
No, even with that, if you're going to rely on one machine, I showed you in the data. Even the IOL master may not match with your manual key, and manual key may be right, actually. So what I'm trying to say is that
From an optical biometer and the axis ideally should be referred from a topographer or a tomographer.
IOL master reasonably gives good access. The question is not that which one gives the best. The question is between the two, if you get consistency. That's the main idea.
Okay, so good afternoon, everybody. I'm Dr. Swati Agarwal, and I'm going to discuss today on the preoperative and the intraoperative digital and ink marking techniques for toric IOL implantation. Well, for any toric IOL to give results with accuracy and precision, the reference markings should be spot on. The reference markings could be slit lamp assisted, bubble marking, freehand, the digital marking, femtolaser assisted, or straightaway the intraoperative aberrometry. Well, coming to the slit lamp markings, the patient is sitting upright and a fixed point straight is, and looking at a fixed straight point, and a thin coaxial beam is then turned to 180 degree, and on a dry cornea, we can mark either with a pen or a 26 gauge needle. Well, I personally do not like marking with a 26 gauge needle because it scratches the cornea on the day of the surgery. And if you have multiple cases, then you need to rely on your technician to mark it with a pen, because then the movement of the patient becomes a problem. Well, the next technique would be the bubble marking technique. Well, here the 3 foot points are marked with ink, and then after a speculum has been put, the bubble is kept in the center of the lines, and then we gently press it on the corneal limbus, like we can see here. But then again, what the patient feels, it can somehow be a little cumbersome and something blocking the front of the eye. Coming to the freehand technique, well, on a dry cornea, the patient has to look straight, and we mark. The tip here is marked with the tip of the pen. Do not use the side edges, because then we get a thick mark. So what we need is a thin mark, and mark only once. So how do we confirm whether this reference marking is at the axis of 180 degree? Well, this can be confirmed by various smartphone apps available online free on the iOS platform. We have the Toric by Dr. Graham Barrett, none other than him. And on the Android platform, we have various such apps like the iToric we shall be discussing here. Well, the iToric app, so we just need to download it from the Play Store, and we open the app, and this is a gyroscopic assisted app. So when we're turning the camera right or left, the axis stays at 180 degree. It's not turning. So what we need to do is just switch on the light on the camera itself. Now gross alignment of the circle is done. Keep the mobile rotation at 0 degree. Align the corneal reflex at the center of the eye. Take the photograph. Manually adjust the cornea with the circle. Manually align the cornea with the circle now, and press on the protractor sign at the bottom. So this gives us a red line. Now drag one point of the mark through the ink mark and the other through the center of the circle. Now we get the misalignment at the top. So another tip here would be to pass the red line through the ink mark at the limbus, because the ink mark could be tilted. So if we are doing it post limbus, then we are not getting the correct marks. So just take out the ink mark of the limbus. We need to mark it there. So this patient is now shifted to the OT, and on the OT we held the Mendes ring in the left hand and the axis mark on the right hand for a right-handed person, and marking the steep meridian is done, and the 90-degree axis, if you're operating at the 90-degree axis, mark only once. But again, the fallacy here is that it could be there could be double marks, there could be smudging of marks or fading away of the marks. So we have the image guided systems to overcome it. So this image guided systems with no financial interest, well, I'm displaying here the Varian measurement unit with the near infrared LED lights. It measures the sphere and the cylinder power and the axis of the central 2.8 degree millimeter of the cornea, and uses multiple reference points on the conjunctiva, the limbus, such as the scleral vessels, limbal vessels, and the iris features to create a digital overlay between the live surgery image and the images taken preoperatively. So these points are passed on to the vision planner and then to the Varian digital marker. Like here in the OT, we can see that we get all the marks, the incision marks and the primary axis, everything. So how do we proceed with it? I've put my incision at 90 degree, and you always follow one particular axis for your toric IOLs. If you're operating temporally, always go for 180 degree, or always go for 90 degree if you're operating superiorly. It also gives us, the Varian digital marker, the rexis markings, so that there's a continuous overlap. It helps us in a continuous overlap of the optic of the IOL. And what we need to do is just proceed with the normal surgery. And after the phacoemulsification has been done, we just need to implant the IOL as smooth as it is, without worrying about the orientation of the chart and which axis to give. It just makes the mind of the person, the mind of the surgeon, very calm and peaceful. So over here it's marked at a 2 degree. We also need to wash behind the IOL so that their post-op rotation is limited, and this is how it is done. So comparing, there have been various studies which tell us that the digital ink image guided delivers better outcomes than the slit lamp assisted and the conventional manual ink marking techniques in terms of astigmatism. Well, over here I would just like to mention to all of you that whatever works in best in the hands of surgeon, please go for it. You do not have to go for all sophisticated instruments to start your toric, but yes, once you've built up your practice, you can always go for whatever fancy instruments you want. But initially, please do go for any of the techniques which works best in your hands. Like over here, we had the left hand image is of the smartphone assisted, and the right image is the image guided. So the smartphone is showing a mark rotation of 4 degree. Now when we put the same patient on the digital overlay, that is again showing a rotation of 4 degree. We've also done a study on this, and we found very good results have been published elsewhere. So now coming to the femtosecond laser markings. So this can be corneal marks, the femto laser can give us capsulotomy marks. Well, though the capsulotomy marks are supposed to be more reproducible, sharper, radially closer to the IOL plane, I personally prefer the corneal marks because I don't like marking the capsule. So this was a patient. The phacofragmentation with the femto laser has been done and the femtorexis has been done. So I'm also marking with the ink. So after the Mendes ring has been applied, we can see that below the rings there is a faint axis mark which has been done intracorneally by the femto laser. So it is very accurate as far as my experience is concerned in all the femtotoric cases I have done till date. So, another advantage of this is that this marks not just guides us intraoperatively, but also post-operative alignment it shows us. The post-operatively, we can very easily see that it is aligned. So again, another technique is the intraoperative aberrometry. Well, it gives us real-time measurement, it gives us a live refraction, it measures the phaking and the pseudophakic refraction and helps us measure to choose the IOL power and adjustment of the rotation if needed. But well, the results can be skewed with surface changes, OVD choice, the IOP maintained, etc. And again, it just guesstimates the ELP. It's not a foolproof method, but what I can say to sum all this up is that the future is here, and are we ready? And we should be ready. Thank you. So do I have questions here from the audience or from the co-instructors? Anything they would like to add upon?
Yeah, about the smartphone marking, I mean, most of them would be interested. how, I mean, you said that you have compared with the variant,
Yes, sir.
but then when you take that initial photo, do you go to, I mean, it's saved in the phone, and then you go back to the patient and again you mark it, or I mean, I was not very clear on that.
So, sir, when the smartphone marking is done, well, the patient is sitting upside, his head is straight, and the patient is looking eye to eye. That light is shown, and there should not be any tilting of the head. So, we need to see whether the light is passing through both the pupil of the patient. So then we know that it is 180 degree. And then once we've taken the photograph, we know that this mark is not at 180 degree, it is at 2 degree. So in the OT, we just need to remember that this mark is at 2 degree, and we need to align the Mendes ring accordingly. We need to consider that 2 degree as 180 degree.
Absolutely.
So we need to apply that Mendes ring accordingly and just proceed with the surgery.
See, it's a basically Geldiver algorithm. Basically, it is like eye trace. You just mark freehand in both the place, and you do the eye trace, and eye trace will show you it is how much degree difference from the 180 degree. That Saurabh Patwardhan has that app is basically same, but you have to do this freehand manually, and very difficult to focus central part of the cornea. To be frank, I tried a lot.
We are trying to.
But if your hand is very steady, you can't do it.
But you can move the circle and you can.
Yes, just that mark you have to mark ink mark first, and take a photograph, and that caliper you how much from the 0, and then you set that mark. Say that mark is 10 degree. Then you your axis marking with reference to that.
So probably will it be better if you do a bubble marking and then use the
Sir,
camera
I don't
rather
go for
than
bubble markers. I go for freehand marking or the variant marking, and in my experience, I've got very good results with freehand marking. Confirmed with this smartphone. And like for the people who, like for steadying your hands, what you can just do is, you can just put one finger on the forehead of the patient and then, stabilize the camera and take it.
Only 6 o'clock?
Pardon?
No. 180 side.
So we can mark anywhere, we need not even mark, we can consider any iris vessel or any scleral vessels for that, and just assume it to be the mark instead of manually marking
then
it.
you compare with the
Data with the variant.
Saurabh Patwardhan app.
Yes, then we just
Yes,
take that
I
mark,
see.
like if I'm
This
taking
is
this
the
scleral
same
vessel
principle-
and just...
Same principle we are using in the eye trace machine.
Correct.
Yes, but it is a very cheap, consistent, and for the beginners, it's a
But yes,
wonderful tool.
very
I would
difficult
suggest
to-
everyone to try that out.
So I just thought,
Practically, it's very difficult
can it
to
be
get
mounted
the
on a
picture of, corneal photo.
some sort of where see, the only problem is putting that hand steady and ask it. So can it be mounted on a slit lamp or some sort of device and ask the patient to
But so
look?
you have to take it really close, so you can't mount it
So
on a
you
device.
can just put one finger on the
Finger, right.
forehead of the patient and stabilize the hand. So then that doesn't
So
work.
I think the best part is, like Dr. Swati said, that it is difficult. Even the Toric cam, which is a little better than this one in terms of its taking pictures.
Right.
But how we started off, like Dr. Swati said, if I don't have access to a variant on that day, I will do a manual marking and just use it in, let's say, 10, 15, 20 cases, so that you know that typically you are off by 2, 3, 4 degrees. Normally, we have seen that even if you do just simple ink marks, 0, 180, you will be within 5 degrees on either side. So just do it in 15, 20 good eyes, myopic, or where you have good exposure, and find out what's your average deviation. So you don't need to do it for every eye, because that's too much of a stress, like Sir said.
Right.
Quality of the mobile picture are not so good. So we need something better which can take better pictures. So blood vessels all are visible. So we can design some manual image guiding system because that type. And second thing I want to say that when we are predicting PCA, all the machines, they are some extrapolating, some measuring the entire the ACI, OCT and something. I think Cassini may be the best because it is taking anterior and posterior both at the same time. It is measuring the physiology. One ring of the anterior
measured and predicted.
Other are extrapolated.
Predicted.
So for most...
Marker is a predicted. But even anterior has a measured one. Now the machine has
So even with...
measured the corneal
So for most practical purposes, a measured PCA is equal to the predicted PCA. So we can all, for most practical purposes.
I have seen one study that I have understood that for anterior, Cassini and all are same. Okay. And but for posterior, there are variation in the Cassini and this IOL master and all the Pentacat.
That actually there is a top over Dr. Sagar.
See, one
I
thing
would
is-
request
one
Dr.
thing I
Ajaypal
just
to
wanted
get ready
add
with his
one
presentation,
point,
sir.
that if you have a with the rule, then you will have a consistent against the rule PCA. That is very clear. If you have a with the rule astigmatism, you don't worry too much about PCA. The problem happens if you have oblique and against the rule astigmatism. That's where the posterior coronary curvature can show variation.
Only in 10
Still,
to 15% cases.
still about 50 to 60% will have against the rule, but the quantum can vary. You know, the spread is from 0.2 to 1 diopter. You can have that.
So I think there is good news in that sense, because see, I mean, there are so many instruments, and you don't just buy an instrument for the posterior cornea. There are many factors you consider when you buy a topographer. But the good news is that when there is a study which showed Barrett universal formula with predicted posterior, that means what they normally do versus IOL master measured. In fact, the predicted was, if not a shade better, but not inferior. So I think for most 90% or 95% cases, we don't need to worry about measured PCA today, at least. With the level of technology, not everybody is actually measuring.
Yeah.
So it's a lot of assumption in both sides.
Definitely, you can invest in one can have a good smartphones. People are going for smartphone photography. So the quality of smartphones definitely is not much of a matter of concern. We can get scleral vessels through it and definitely go for ink marking, if not these scleral vessels. And so our next talk would be on femtolaser, arcuate keratotomies and toric IOL surgery by none other than Dr. Ajaypal, who has been a guru and a mentor to many in Kolkata, including me. Sir, over to you.
Thank you, Swati, for having me in this course. Well, I have no financial instrument disclosure, because the instrument that I'll be describing is the one that I'm using for last 5 years. Maybe 5 years hence I'll be using another device. So this is about, I'll be talking about the Catalyst platform where we do the femto for last 5 years. So astigmatism management, we had a talk just now, because moderate to severe astigmatism is highly prevalent, as Dr. Shugato said, in patients with cataract. It can be as high as 40-48%. And what you know, in 2019 market survey, this is American survey, only toric IOL is used only in 33% of cases, which are there already, and 49% of cases no surgical attempt was made, even in a place like USS, even on our own situation. So this, I'll be talking about the Catalyst COS 6.0. You know, this is the new software they have got. It's the advanced astigmatic management to manage astigmatism for easier, faster and more accurate way of dealing with it. So you have got direct entry of preoperative data, and if you have got the Cassini system, it can just go and interpolate that system. It has got a built-in nomogram now. It calculates on the arcuate incisions and parameters and automatically enters them into the treatment planning stage. And you have got the radial laser alignment marks. These are the corneal marks that come with it, which reduces your reliance on intraoperative aerometry for toric IOL alignment. It also gives you an increased operational efficiency. It's got direct entry of pre-op data, onboard nomogram, and import of iris registration from the Cassini, as I said. Now, if you look at this improved intraoperative accuracy, the automatic system with the cyclorotation compensation is very high. It's 2% of less in 94% of the eyes. Now, this is the study by Koch, Wang and Dewey. This was presented in 2020 in ASCRS, and the error that would be get as against the manual measurement was a 4-degree alignment, which with the Catalyst COS, the new Cassini incorporated is 1 degree. We are not using Cassini. We just put the pre-op data from the IOL master, and that's how we got the results. So this is the again study which said that is the arcuate incisions clinically validated within 0.83 plus minus 0.66 of the intended optical zone, and 0.22 plus minus 0.2 in the intended axis, and intended length also is 0.22. So it's reasonably clear. And this is the Donenfeld, the nomogram that is incorporated there. I mean, you had it for the LRIs. This works simply better for the arcuate incisions, because the LRIs are, peripheral 10 or 11 millimeter away from the periphery, and this is around the 8 mm within the cornea. If you look at it from the center, it's 8 mm. So probably that's why you are attacking somewhere in the mid cornea instead of the peripheral limbus. So that's what these are the incisions length that we are working on. This is the intrastromal, the femtolaser assisted intrastromal arcuate incisions. As you can see, these are what we used to do it to open the anterior end, but then we have stopped doing that because of the various complaints. So now look at this. This is what we are talking about. You can just feed those values here, and if you're looking at that, you can see where I'm putting in the what degree, the intrastromal or anterior penetrating. I can put the cylinder that I have just, and that's the intended arcuate incisions that would be there. And again, when you dock it, that's where the docking takes place with the acini. You can see the anterior corneal OCT being done, and that's where you can just place it, and it shows the steep axis immediately and at what axis it has to come, and it's this, and this is the intrastromal that will be there, and look at this. This is the two cuts that have come intrastromal, and as you go ahead with the surgery, so you can remove it, and at the end of the surgery, and these cases basically what we do up to 1 diopter. If let's say above 1 diopter, definitely we would say that going for toric lenses. Now this is when we are using the toric lens, this is what we are saying, mark it outside 0-180 degree. This could be augmented with your smartphone. Yeah. And when putting that LOI, you have got 0-180 degree, the marks are there, and just put it, align it accordingly. And then now this is an example where it shows 169 degree where the lens would be placed, and when we actually, these are the two corneal marks that come, it's 169 degree. Now if you correct it, we can check it there, and actually it's coming that the same way. I can remark it just for the sake of checking it, and at the end of the surgery I can align, I can put a bit of ink mark also in that, and if you don't want, you may not put it. The lens can go in and you can align it accordingly. This was a multifocal, toric multifocal, where we are aligning it along the marks that came in the machine. And this is again another showing a 50 degree, and this is the alignment. Look at this, and as we look at the calculator, see that immediately we have got those two incision marks that are supposed to be come for the toric IOL. Now there are newer machines which has come, the Zimmer 8, where the marks are on the rexis margins. There is on the rexis there is a small notch there. So with the Cassini, with the integrator, I suppose with the even the Varian and the Lensex, the same astigmatism work has been done. So where directly can be incorporated for Varian there. And as you see, this is again the mark, that is very clear mark on the cornea. We can just recheck it, and that's what at the end of the surgery. So the marks, you can, and in case you have a small pupil, I mean expecting a small pupil, you can put a mark also there, and then see at the end of the surgery what we are trying to do is just recheck whether that marks are okay, and that gives us a really good result. And this is again one patient where the pupil has become small, and that's just marked it blue because we expected the pupil would get down by the end of the surgery. Just augment it with a pen mark, and this is just as the pupil came down. Got the just putting it under visco. Normally I would not put it under visco, but this was again, see, you can just go and compare it with the, it just matches. And this is one of the study that we did, the visual outcome with the arcuate keratomy, the femtosecond laser assisted, and we generally got a consistent, just a residual for the less than 1 diopter 0.33 and 1 to 1.5 0.25. So it does work for the arcuate keratomy up to 1.5, but generally we prefer it doing below 1. And these are the various studies which have said that the arcuate keratomy definitely works up to 1 diopter very well. Thank you for your patient here.
Thank you, sir. That was beautifully covered. So do we have any questions here? Sir, what is your, what consistency, how long have you followed up these cases, and what is your cutoff? When do you go for toric IOLs? When do you go for arcuate keratodermy?
See, all patients that are there, I mean, those who would not go for a toric IOL or not pay for it, when we'd go for either the eye hands or EMV, anything above 0.5, I am going for arcuate keratodermy. I would say anybody above 0.75, I would advise the patient to go for toric IOLs, especially again astigmatism, even if I have, but this is an extra tool that I would not have corrected in normally, but since the patient is going for a femtocataract, even if he's going for a normal monofocal lens, anything above 0.5 I correct with the arcuate keratodermy. Above 1 I definitely tell them that, but I have done up to 1.5, and it's, I mean, patient could not afford, or patient has gone in for eye hands or EMV lenses up to 1.5 the arcuate keratodermy. I would have had problem earlier when I did for a 1.7 or 2 diopter patient, the anterior opening, patient did have complaints of dry eye, a lot of foreign body. So right now for last year or so I have stopped the anterior opening, I just keep it interstromal, and it absolutely works up to 1 diopter. So 1 to 1.5 it's working, so I have followed up for the recently, but for last 5 years, well, I've been having absolute result.
What about the age of the patient? Does the correction vary with the age of the patient, the corneal rigidity?
Yeah, corneal rigidity in the younger age, probably not over a period of time, because as the eye grows up, astigmatism we know with the corneals, but it's people above 65, 70, well, they are going in for a femtocataract, they want early rehabilitation and all, maybe they would not pay that extra. Definitely this is an extra armament. I never tell the patient that I am doing a astigmatic correction for you. This is something I would not have done it, but then for all, even for the multifocals, I mean, I'm using a particular brand which still do not have a toric trifocal, and the other ones do have. For them, even for 0.5, I'm putting an arcuate incision.
What is the duration of this arcuate?
See, last 5 years we have been following. Below 1 diopter, absolutely no regression. Between 1 to 1.5, very variable. Above 1.5, you do end up 0.75 and 0.1, but 0.75 and 1, this is what we have been doing regularly. It's absolutely
If you
minimal.
correct 0.7, even there is a regression, some amount, it doesn't matter.
See, after 1 year, patient forgets.
We have never tried to correct the high cylinder here.
Yeah, absolutely.
It is an additional benefit.
Benefit that you are doing. That's it.
Monofocal lens, not paying extra for the toric IOL. Patient having 0.75, 0.8, 0.9, we do the 8.
See, had we had a choice that with the best of the monofocal, say it costs around, if you look at around 6,000 to 7,000, we have always told them that keep it, say 20%, 30%. They have double the price for a toric. So that's limiting you. So those are, they expect that when you give them, you do surgery, I should be seeing distance clearly. For near, most of the people above 40 are used to glasses. चश्मा नहीं मेरे चेहरे में सूट करता है, नहीं करना है, ठीक है. Trifocal is not. But monofocal toric should be made just 20 or 30, because there's no rocket science in that, I suppose. So, but then it's not a premium. We should not call it a premium IOL. We just call it a better mono.
It should be a regular armamentarium. Is
Dr. Vaishali and Dr. Paul, how are the results with Indian toric? In my hands, I have seen the Indian toric results are very good actually.
I think a lot of people
Very
are
good.
using, and they're very good. Of late, I have started even using
And
oral
as
ones.
Dr. Paul said, there is no rocket science, probably.
Yeah.
There's no rocket science. They just have to, but the machine they have to
But
just
again, Indian torics, they have price double, more than double.
more
of
than
their-
double. I mean,
yeah.
they're following these. They're his masters.
Yeah, why should our companies not earn? They are milking us out, so our companies will also milk us out.
Thank you. Thank you, sir.
Thank you, sir. So the take-home thing over here should be that we should be well versed with whatever comes our way, because I had a patient who was lawyer to the ruling party of the state, and he came to me, I am myopic, I don't want to go for toric, do me a femto AK. So this is a kind of awareness the patients are having nowadays, well,
That is a relative of Agarwal.
yeah, so rather than doing research in his own subject, he is now doing research for this. So we need to be
Problem is their children. They are always on the. I mean, they may not be. Their children say no. This is available. This is available.
So yeah, he is doing well. So with this note, I would now invite none other than Dr. Vaishali Vasavada, who needs no introduction and has been a key instrumental Toric IOL implanter all over the country for the last many years. Let's hear from her about multifocal toric and challenging case scenarios. Over to you, Dr. Vaishali.
Thank you, Dr. Swati, a very dear friend, and I'm so happy to be here. And I'm really happy that on this last day, last session, we have a full hall. So hats off to you, Dr.
Wonderful.
Swati.
Hats off to the audience, actually.
Really.
And they're so interactive.
Correct. So I'm enjoying this course, and I must say that we do have occasional research support grant from Alcon Laboratories, and all of us have a financial interest in torics and in multifocals, irrespective of the brand. So my talk being more on multifocal and special scenarios, I think we need to understand, as has been discussed all through the course, that any residual refraction, particularly in a multifocal or a trifocal or an EDOF, whatever, is going to adversely impact your outcomes, and it is typically the most common reason for a dissatisfied patient. So I think it's learning or having a mastery of toric IOL or any kind of astigmatic correction is a basic stepping stone before you even start a multifocal practice, because in today's date and time, with as small as 0.5, 0.6 being correctable, we have to do that if we are also planning to give the patient a spectacle freedom. So I think that is very important when we start the background. And for us, when we do a pre-op assessment, the most important thing we look at, first thing, is the amount and the type of astigmatism. We'll decide which way we are going to counsel the patient, and which was very nicely mentioned by Dr. Bhargav also, that it should be and in the first talk also, that it should be the first evaluation, and the patient should, as soon as the optometrist or your technician sees an astigmatism, they can even just start putting a word about this availability of a toric lens. It may or may not be suitable for you, but there is this thing which is already available. So like I said, if the patient has a negligible astigmatism, we will go towards a monofocal or multifocal. When I say, I mean a trifocal or an extended range of vision in today's technology. If there is significant astigmatism, it is either a toric monofocal or a toric with extended range or a trifocal. So that sort of classifies our thing. Where is the cutoff? As we have discussed amply, I won't go into this, but anything 0.5 or more, we have to give the option. And like Dr. Paul said, maybe you will do a Femto AK if you have access. If the patient is already paying more than double for his surgery, his or her surgery in your Femto, you might as well add in this, but you have to address the astigmatism. And the preoperative evaluation, which I don't want to go into details, was very beautifully covered, has to be to the mark. If you don't have access to a topography, probably when you are planning multifocal torics, this is the time when either you do it at your place or refer it to a colleague who has a topography. In a monofocal toric, you might still get away sometimes. And I think the good news now is that there is too much of counseling and talking about the negative side effects or personality assessment. With the new trifocal torics and across platforms, I don't mean any one brand, all the 3 brands that are available, and in fact this meeting I even heard 1 or 2 Indian companies have launched their trifocal torics as well as EDOF torics. So now we have these available. Trifocal toric is my #1 choice for anybody who says that I don't want to wear glasses. I don't think too much if the eye is a suitable candidate. If somebody is very, very particular in terms of their personality, or if their eye has something which is not exactly within ±2 standard deviation, then I would go for an extended range of vision IOL and astigmatism correction. So I think there are negligible side effects, and I'm sure everybody on the panel will agree that the glare, the halos, the waxy vision, they have not gone away, but they are not so much of a bother for us so that we hesitate in suggesting these lenses to patients. Let's go to some case scenarios. Here is a young person, 33-year-old, and unfortunately post-COVID we have been seeing so many people below 40 and we have been operating them. So now it is even more important. And like we discussed, yes, when maybe 20 years down the line this guy will have and shift towards against the rule astigmatism. Right now you have to treat for now and the youth, prime of the youth that they are going to be in. So one diopter cylinder in the refractive correction, and the other eye has already had a surgery elsewhere with a full optic diffractive multifocal IOL, and this is after that multifocal. So left with a residual astigmatism and therefore very, very unhappy, and now says that I don't want a multifocal because not only I have not gotten rid of my glasses, I also have these other problems of the multifocal. So what would you do now? Safest is to put in a monofocal and say, or a monofocal toric and say that, yeah, okay, get on with glasses. But then that's the whole thing, that if you have access to technology and if you understand the eye well, you can even do a second eye of a little bit unhappy patient. So what we saw, this is the operated eye, and this is an abrometry. Just to orient those of you who don't know, this is an eye trace, ray tracing abrometry. Pointer hai? I'm not getting my cursor on this. So if you see the bottom left, that is the astigmatism coming from the cornea, and the top right is that coming from the total eye. So which means that the cornea is contributing to his entire astigmatism, which is about, even in the eye trace, which is a beautiful autoref, it shows 2 diopters of cylinder. And which is why the visual quality is like this, because the cornea is giving rise to a blur. So the good news is that you can correct it in the other eye. Now the other eye, which is the left eye, has 1.5 diopters of with the rule astigmatism, and otherwise ocular profile is suitable. So we did cataract surgery with toric IOL here in a monofocal, because like I said, the patient just didn't agree to get a multifocal even despite 2 or 3 counseling sessions. The other thing I also want to highlight is that in any case of a multifocal or toric or such an odd challenging situation, it is very important to have more than one session of counseling. It is very rare that patient is so crystal clear in their mind that this is what I want or don't want. And sometimes the right relatives, like Dr. Agarwal pointed out, are not there with them. Or you may have to talk to them on the phone. Okay, please talk to my son who is in US or this, that. So have more than one session and tell them that these are the options, and then most likely they will go for the one that you suggest. And this is the postoperative picture in that other eye where we did a monofocal toric IOL. Again, like I said, just because the patient was so scared of having a multifocal. So many times the multifocal lenses get a disrepute just because they were left with a residual cylinder. So that is another point, that we need to explain to this patient that it's not the multifocal, it's just that you have some astigmatism. Now we go to this another scenario where this is a middle-aged gentleman, and I say middle-aged because as I grow older, my bracket for middle age also keeps moving up. So bilateral cataracts, a very active lifestyle, and plays golf. Now his main thing is that now that I'm going to retire from my active profession, I want to be able to play golf all day long, 5-6 hours a day, and I don't want to wear glasses. Now golf, as we all understand, is a very sunlight intensive game also, a lot of outdoor exposure, a lot of dryness, everything is going to come in. And this person has a regular corneal astigmatism. So we did trifocal toric IOLs in both eyes after a very good counseling session, or let's say more than one. And he's very happy now because his whole thing was, I want to play golf without glasses because my colleagues feel that my glasses keep slipping off and all that. So I think again the point here is that with the newer IOLs, these dysphotopic phenomena are, I would not say not there, but very, very less, and therefore you can do toric IOL or trifocal or any form of multifocal toric IOL correction, even in people who have so-called red flags. In about 10 years back, we used to say with the +3 and +2 type of IOLs, we would say that please don't do that because they would have a lot of glare. Now moving on, toric technology in general, how we keep expanding our horizons as we ourselves learn from our good and bad experiences. Now this is a 42-year-old lady, known high myope, and radial keratotomies done several years back, and you can see that she has a typical nuclear cataract with some degree of posterior subcapsular cataract also. What is important to note here is that look at her case, 31 and 33 almost, and obviously a high axial length. And she has about 2 diopters of astigmatism, which you will see here. Now, to our surprise, and thanks to the RK surgeon who spared the central cornea, the central cornea, if you see on the topography, has a very regular astigmatism. Now, what we need to see, most devices, all topographers, pentacams, abrometers, they will give you the patient's pupil size during the scan capture, which is this black circle. So, and also what we do as a practice, at least for those of you who don't have the highest end SSOCT, the swept source OCT, the newer machines say that they are going to be independent of the illumination. But until now, whenever we capture a scan, it has to be done in a mesopic light. That means you don't necessarily have to put a black curtain or cloth over the patient, but switch off all the room lights so that in a physiologic mesopic condition, what is the pupil like? And we being pigmented races are usually blessed with not so dilating pupils. And like you can see here, it gave up IOL power of 30 diopters, T4 model of that particular brand, because the mesopic pupil has a regular corneal astigmatism. We also did an abrometry, and we found that again the same thing. This has also a Placido disc topography, and again coming to the point that in these eyes, these are the eyes when you want more than one type of technology. In a regular patient, it's okay if you just have one or max 2. But here we confirmed it with the eye trace or the abrometry. And we found that the total higher order aberrations were not that high. And we went to the ASCRS post-refractive calculator, which still is our go-to and again freely available. And this is what the patient looks like post-operatively. You can see beautifully the toric marks there. And so again, you can see here that the central cornea looks pretty clean. And therefore, 1 month follow-up, she's 6 parts plano. You don't expect a 6x6 in every eye. This eye probably never had a 6x6 because she's been a high myope. So the point is good functional vision. Even if it's 6/9 or 6/9 partial, for that patient, that's the best vision they have ever had. So that is something we need to keep in mind. And post-operatively, this is corneal astigmatism being cancelled by the intraocular. Now, this is one last case I wanted to show. This is a 53-year-old share broker and has always been myopic, moderately myopic with some astigmatism, and he wants to continue his distance glasses and not wear reading glasses because that's how he's been used to. And we did a toric IOL calculation with a target myopic refraction. So the point is that there will be those occasional patients who are not ready to give up their unaided near vision and who don't want to, or who may not be suitable candidates for a multifocal technology. So in these cases, you can definitely consider toric IOL even with a myopic target. The whole idea is to give them good quality. So even for near, if you knock out the cylinder, their reading vision quality is going to be much better. So that's one message I wanted to show. And the last case of a pterygium, which is also a very common scenario. In a significant pterygium which is causing distortion in your readings, do a pterygium, wait for at least 4 to 6 weeks. So this was the pre-op, very irregular astigmatism. This is what it became post-op and the mesopic pupil. So you could very well go ahead in such eyes and do a toric. I think the most underrated thing is your staff and your team, because unless everybody talks about toric, unless everybody shows that confidence on their faces, on their language, it's not going to work. It's not going to go to the level that we want it to be. Thank you so much.
Very nicely explained all the facets of multifocal toric and the scenarios. So do we have any questions from the audience here? So Dr. Vishali, what happens if during the operation you face a PCR or a rhexis run out? What do you do in those scenarios? Would you go ahead with a multifocal toric, or would you change over to a toric or a plain monofocal?
So that's a very tricky question, and I don't think it has a clear-cut answer, but if we look at a rhexis run out, if at the end you end up with only that localized run out, it has not extended behind, depending on again the kind of material that you are using. Most hydrophobic lenses across platforms have a very sticky nature, so you could go ahead and do that. But again, I would be very cautious because the other thing is going to be the tilt. So if you are very, very confident in your surgical outcome, then that is one thing I would do for a monofocal or even a multifocal, and I have done because I tend to have all kinds of complications. In a PCR, general answer is no, because it's not only that multifocal toric, there are so many other issues that are going to come up in the future. So as a general answer, no, but sometimes we have done small central PCRs, converted to a Rexis and then just put it in.
So I think it depends upon the surgeon and their expertise and how you want to go ahead with it, the patient expectations, the patient who's lying on the table. So there are multiple facets to this. Dr. Ajay Paul, sir, what is your take on this question?
I have had quite a few, if not all, the plain multifocals, the torics, with a little bit of Rexis run, is not gone in, pressed it. I'm talking about all the hydrophobic trifocals rather. Very recently I had even had a trifocal where in a femto the Rexis had bit runoff, and I'm following those patients for almost 9 months. So normally it doesn't, but yes, torics probably a tilt would come in if it is more, because there would be a tilt even with the trifocal, but somehow, with the patient, if the pupil is the big pupil is small, it doesn't give that much of a problem. With the toric, maybe you would again get up with some cylinder toricity, but then yes, I would not hesitate to put the lens.
So would you like patching the patient and giving?
Yeah, normally again, this any I just forgot to say, for high myopes, for where I haven't had a difficult situation or I put in a toric, it's always I keep the patient 4 to 6 hours patched in my hospital, send the patient patched, and maybe for 24 hours patching. All high myopes in torics, I do that, for at least 2-3. See, the idea of patching is, especially these high myopes or myopes, the lens is there in your bag as the year forms up. So the idea of patching, keep the eye in rest. Any stress, patient gets up and walking, there would be a little bit of forward and backward movement. So that could rotate. I mean, there have been instances where we have put in a eye myopic, anything below 18 diopter or 19 diopter where I'm putting in toric, I normally
rotation we've seen in the first 24 hours. So it's usually ideal to, limit the movement of the patients in the initial 24 hours. Tell the patient to take rest in a dark environment, not talk much, not move his eyes. So we usually, say, we've done this premium IOL, go home. So this is how it is marketed usually. But for toric IOLs, just be wary of this. And it's like a little under counseling, stay at rest for the first 24 hours.
So I think that this is a great point, and there is a very beautiful study from, I think, Japan or Hong Kong, which showed that the maximum
I'll
rotation.
Present this.
Sorry, then I don't need to say anything.
Actually, there is a constant leak from the anterior chamber to outside. It's fast 24 hours. In every cases, either you hydrate wound or because there is too much of pressure inside the eye, it will leak somewhere. So it is always from inside to outside, never outside to that's why there is an incidence of endophthalmitis is less. So there is a fluctuation of IOP in maximum in the first 1 hour and after that. So it is, if some surgeon prefer to patch the eye 1 hour in cases of toric, it is a good idea. So my topic is postoperative assessment and alignment. The postoperative surprise or residual astigmatism. These are the common when implant toric, and this incidence is less now, but it could happen in any case. So what could be the reason for this postoperative surprise or residual astigmatism? It could be the wrong IOL selection, or it's a misalignment. Misalignment, there is maybe the wrong axis of implantation, or maybe there is a rotation of IOL postoperative. So these are the basically workflow. You the biometry, data transmission to your optom or your who are maintaining the stock, IOL selection and reference marking, axis marking and IOL implantation. That anything which happen, there could be a ultimately residual astigmatism or refractive surprise. So the first three, anything wrong happened in the first three phenomena, there is a biometry, data transfer or toric calculation, because it is done by manually. But if anybody want to put the 40 instead of 46, just write your technician 44, there will be the wrong calculation in toric calculation. So that could be ultimately gives a wrong IOL. And then if you make a reference marking wrong or then axis marking wrong or misalignment, there will be the misalignment of the IOL. What will be the threshold? Threshold monofocal, you can go up to the 1 diopter of residual surprise. So because sometimes goodness is better than perfection. So it is not try to correct every postoperative astigmatism, take into the patient into the OT, try to rotate that. But even ultimately if patient is happy with the 1 diopter cylinder, I will not prefer to touch. But definitely in the multifocal IOL, the threshold is very less, because there is a lot of study that the quality of vision, even 0.5 cylinder, will be very less in case of diffractive IOL. And this is a study at Dr. Boishali is doing. This is a large study. The initial study was a 72 toric IOL, and it is shown that the mean alignment after 1 year is 6.6 degree. So it is 6.6 degree, it is a reasonable. If you just, there is a 6.6 degree, you loss of toricity is basically 15%, 16%. And surgical misalignment is basically 20%, 28%, 2.3%. But even it is very negligible. But the 1 hour, after 1 hour, he take the photograph every minute after surgery, and it is shown that the maximum rotation of the IOL happens in the first 1 hour of the surgery, because there is a AC fluctuation, pressure fluctuation. So and probably doctors was in hurry, they did not allow to they did not wait to allow to unfold the lens completely, sit in the bag. Probably maybe the different factor, but the most of the time the misalignment, rotation of the IOL happens in first 1 hour of the study. So if, and we are considering we have to control these, because now if those are using the digital technique they have basically avoided all the manual entry, because it comes from the biometry to variant to direct to land to your OT and to microscope. So there is a minimal chance of error in this case. But even then, you are using the manual marking, if there is some wrong in the reference marking, which leads to actual wrong in the actual axis marking. So what are the reference marking? As Dr. Swati said, it is a manual marking or digital marking. There is a different study, but I made in my study, I used different kind of manual marking before I switch into the digital marking system. Now in 3 OT, I operated 3 OT. One OT has a Callisto system, another OT has a Variant, and another OT I am using the still manual marking system. And in my hand, this is the best, probably the pendulum kind of manual marking, because it always keep absolutely horizontal. Even bubble marking, it's very difficult to keep the bubble in the center. So this probably the best one, and you can it's always keep horizontal, the pendulum marking, and it is give a beautiful result. Every time whenever you ask for any marker, bubble marker, pendulum marker, you have to check your instrument. It is basically protector. And if you sometimes I find constantly wrong reading on my manual marking system, and I saw that my manual marker was not full circle, there is a half circle, there is a 10 degree lagging, and one marker I saw there is a not that is not absolutely horizontal. So you have to check your machine whether it is give you the consistent result. And it is common mistake by all manufacturer who is making this marker. Like it, see, this is sometimes in a manual marking, it is a nightly seat, it's a 90 degree, 10 degree, and 180 degree, 0 degree. So this is a perfect marking. But fortunately and unfortunately, you not get this kind of manual marking in every time. You just show this the next case. You just show this. What will be your algorithm? See, there is a your 90 degrees matching. Can I stop this video once again? Let me.
0 is somewhere
there. Yes. You can see that there's your 90 degrees matching, but 0 and 180 degrees not matching. But here the 0 degree and 180 degree basically same parallel distance from this mark. So let's validate that my 90 degree marking is perfect. That's so I came to the some algorithm here. These are the algorithm may useful those who are using the manual marking system. See, if you are right every 3 point, this is a right. If the patient is try to close the eye and your 90 degree mark is got up, and naturally that is it is got a upside, and that will be the same parallel distance from actual marking, and if you sit the manual marking system, you get this one. And if the patient try to move the eye and the 90 degree mark is got shifted here, but you can get the same thing. You can actually to calculate which is in the actual one. Even then the same thing happened, it is right sided shifted, it is right sided shifted, your 90 degree mark is right sided. These are the 6 algorithm. If you use these 6 algorithm, you can actually reduce the error of manual marking system. These are I'm just skipping this, the rotational stability. Also these are the incomplete unfolding, incomplete OVD removal, large capsular bag, large rhexis and wound leak. This could lead to the rotational instability. And what is the rotational stability gives is the perfect incision, perfect smaller rhexis, relative smaller rhexis, avoid anterior capsular polishing, sometimes give it tackiness to the lens, complete OVD removal. It is better to avoid to inflate the AC too much and notch the IOL before in the capsular bag so that it place in place and ensure position once speculum is off. Now, what is you get the refractive surface. So identify the axis of your placement and what should be the ideal place for the axis. So if see the toric calculator, and if your astigmatism, which is actually residual astigmatism, it corroborate with the axis of deviation, then you are right. That means your calculation is right, your toric calculation is right, your biometry is right, but there is some kind of misalignment in there, maybe from reference marking, maybe from axis marking. So you can go ahead and rotate the IOL. And you can use, this is a very good software, astigmatismfix.com. I use personally this, and this is a fantastic software, and it will give exactly your marking how much you have to rotate your. Now you identify axis. The second scenario, you mark the actual axis and this is not corroborating. This is most difficult part. That means your IOL is wrong, your calculation of biometry is wrong. So then again you go to the astigmaticfix.com and it give you the best possible result after rotation. And if you see that just this is 0.5 spherical with 0.5 cylinder, you accept this, don't rotate that as per that astigmatismfix.com. But if it is actually really different, then you have no other option to expand the IOL. but better to avoid any time. If patient is not complaining so much, better to avoid this. This is that actually astigmatismfix.com. You can put any kind of IOL, even in you can get the Indian IOL there, and it give you accurate result. This is an excellent software. I will suggest everyone to this. This is a eye-trace Zaldevi Toric caliper method, and you can grossly, this is a back calculation of this, but I think the software is not so good, but astigmatismfix.com is software is much better software than this eye-trace one. So we are using Toric calculator, Barrett calculator, which is the gold standard today. But if you are using Barrett TK formula, please use Barrett 2K Toric calculator. But because in that case, it will consider the posterior corneal astigmatism twice if you don't use. So IL realignment is ideal time is 3 weeks, because there will be some kind of fibrosis in the back. So it is very it will be very good if you able to do it after 3 weeks. But if you want to do early, most of the case we have to, in Indian scenario, we have to do the early. If we do the 10 to 12 14 days, especially next week, then I generally prefer never inflate the bag with the OVD. I just inflate the anterior chamber with OVD and try to rotate the IOL. If I inflate the bag, I have to inflate the bag with OVD, I always put CTR. Because if you inflate the bag with OVD, again you wash the OVD, again IOL can rotate. So it would better not to inflate bag with OVD. So if you go beyond 3 weeks, even then you put little bit of OVD within the capsular bag and rotate the lens. Because if you fully inflate the capsular bag, again the chance of rotation of the lens again higher in that cases. And this is I think this is not very difficult to rotate a lens. This is a just put the anterior chamber. As I said, I never inflate the capsular bag. I never entered the capsular bag. In one case, I not able to rotate. I again inflate with put viscoelastic in the bag. In that case, I always put CTR. So this is a simple. I just put viscoelastic in the anterior chamber and rotate the IOL. And all that, I think if I have a question, I can
Yes.
we can discuss this.
There was a plate haptic lens?
Huh?
Was that the plate haptic?
Yes, that's why
I learned from you. I learned from you.
No, you could rotate it
So
very
let me
either
tell
way.
you, Dr. Arup is, they say that quality and quantity don't go together, but with Dr. Arup Bhomik, both quality and quantity goes together. He's a high quality and a high quantity surgeon. Sir, what happens, like if there is an, the IOL has rotated in the first 24 hours, then do you go for it within the first week, say first 24
So
hours?
I
you just
see
rotate it?
generally I assess the patient within 4 days post-op day. So even it rotate in the first hour of the surgery, I can identify. Patient came in after 5 days. So if I identify in the 5-6 days, I plan for the at least I cross 10 days. So that there is a kind of
Some
fibrosis in the
fibrosis.
bag. I will not inflate the bag with the viscoelastic. Just put some viscoelastic antechamber and rotate the lens. In cases there is a instability of the bag, say there is a zonular problem, I understand during the rotation I put CTR.
So on repeat calculation, if your IOL has been changed, so do you did you have to go for
Patient that depends on the patient, how much demanding is patient. How much my commitment towards the patient, how much. Yes, most of the time there is some kind of, as Shagor shows the formula, there is a multiple steps we can pick up the wrong lens. But even 0.5, 0.75, it don't matter. In our patient is
Forgiving, not
don't
always forgiving.
complain so much. In that case, we just avoid to do the research.
We saw the lens being Because it is
There is
plate
a plate haptic. Plate haptic you can do
rotate
it.
both the way.
It was a Zeiss Atilis.
So Dr. Sagar, you have quite an experience of quite a few experiences, though you are always spot on. But
The machines were not spot on.
yeah, so do you have some points to add here? Would you like to say something to the audience?
Dr. Arupa has completely, given everything, but the best part about that astigmatism fix calculator, it gives you a curve. And it tells you where exactly you want the cylinder to be. So you may not correct it to the plano, but it'll bring you to the least possible astigmatism.
Least possible
So
astigmatism.
that you can play around on that and then
This
take
is
a
an excellent software.
wonderful
And
software.
wonderful, and it is a free of cost. The best part is.
So would any of the co-instructors like to add anything here about the torics or otherwise?
No, ultimately you have to know, is the patient unhappy? Is the patient unhappy with that? That is what is more important.
Suppose there is a significant.
Patient even unhappy 6 without correction, the patient may unhappy. So I like that patient who is always happy.
Yeah, so I had a patient. I gave him femtotoric.
Yeah,
and-
there's a question there.
I have a
Okay, yes,
question.
yes, sir, please.
Suppose there is a significant residual astigmatism and you don't want to rotate, go again in the OT and do intra this thing. How you tackle that? Significant residual
If the
astigmatism
patient is
in a
unhappy-
toric, multifocal toric patient, both eyes done, one eye excellent, in the other eye there is a residual astigmatism of say 2.5 cylinder. And patients
You have to do something.
Patient is unhappy.
No, are you talking of the LASIK or bio?
I'm thinking of that. So anything from
So, I mean, like with every other complication, I've had this, though not very frequently, but as we were discussing, I mean, 2.5 is a very gross astigmatism,
Yes,
but we will see many who will have 0.75 or maybe 1 also. So first thing, like Dr. Bhaumik said, don't be very enthusiastic on day 1, telling them everything and correcting everything on day 1, unless it's like a 90-degree you see. So in my mind, there are two things. One, I would like to see all of them on day 1 personally, at least torics and multifocals, because I want to see their general satisfaction level and a slit lamp. Because most of us, we will not dilate and check the axis, and all that is in high volume doesn't work. So, but if you have gross, you have to do something, but counsel them at least 2 or 3 sessions before you touch that eye. Otherwise, just
See, this is a very practical thing which has happened. The doctor's wife, I've operated both the eyes, multifocal toric. She had a high cylindrical in the beginning, right? One eye is perfectly fine, 6.5 and 5 she is reading very good. In the other eye, without glasses, right eye, she is seeing 636, 624. With correction, minus 2.5 cylinder at axis, she goes to 6.9. With pinhole, she goes to 6.5 and all. Now she always complains when I am closing one eye, I am not happy. Otherwise, both eyes, I am very fine. The husband is a doctor. He says, "Arey, pehle bhi to dono aankh khol ke dekhte the na." So 3 months has passed, 3-4 months. Now what can be done? Tell me.
it depends on what's the cause, sir. If it's a 2.5 cylinder, we need to see why is it that she has so much
Acha,
of
in the
it.
beginning, at multiple occasions, I had dilated, I had called the Alcon person also to see. The axis appears to be in a place where I had kept it. Correct? So, because in the beginning I thought if 10 days, 15 days, if it has rotated, I would rotate it. But that was not the case. In both the eye, the axis, it is at the same place. So, can we tackle this with LASIK, femto or anything?
Yeah, I think that's the only bioptics. I mean, only laser.
So
I mean,
is there, just wanted to check, has Care Group come out with a Salcofix toric IOL which can be used in this case actually?
See, I think if it is Alcon
Panoptics?
panoptic stories, you can rotate after 3 months. I don't
but he
know,
doesn't know.
So, but I think
No. Then
the
you
calculation is
calculate in as is a only a cylinder. The calculation was wrong.
correct.
The axis of implantation was right, but the calculation was wrong. But recalculate, put in the astigmaticfix.com, it will show you rotation, how much you have to
I always
put.
send the parameter to the Alcon people and tell them to send their sheet and all. And
No, what-
this is my standard incision place, and you tell me at what axis I have to place the IOL. And
See, Alcon people will not say. Just you put your previous data, and this software you put now the residual astigmatism, and it will give how much you have to rotate.
Sir, we also need need to rework this patient, do a topography, biometry.
Yes.
Because
I feel that extensive workup.
because ideal
No,
solution
no,
would
2.5 cylinder with correction 6.6
Yes.
and with pinhole. That means it is
Exactly.
a
So,
residual
in my
cylinder.
understanding, either a bioptics or an exchange, even rotation of any degree, I don't think can, unless it's wrongly placed, it cannot correct 2.5.
So this needs to be workup and all.
initial
Another one thing I wanted to have your opinion. Is there any concept of smart incision, whether anyone is this thing? Because with a cylindrical difference of 0.5 to 1, when I don't want to put a Toric IOL, because Toric IOL has its own this thing, like placing, it can rotate and cost wise and all as such. So my
Are you talking about LRI?
not LRI.
OCCI.
No, smart incision means my regular is
Yeah,
I sit
strip
at,
axis you
12
can
o'clock
give with
and,
OCCI.
100 degree I take incision. I give it my parameters to the Alcon guy or whosoever lens I am using, and I am telling them, you tell me at what place I should take my incision, so this 0.5 to 1 should be covered in the monofocal lens. And
See,
I am
See,
very
one
happy.
centroid-
Lot of people I am doing it, and I am getting a very good result in this. Smart incision. So in my paper and all, also I write smart incision. So normally I take 100. He says me take it.
Generally, after
0.1 diopter you can correct with
after centroid,
0.1 to
we understand that if it 2.2 or 2.4,
It will-
astigmatism is very less.
0.1. Centroid
0.2
value.
max to max 0.3. So if you really correct astigmatism more than 0.75, 0.75 with just your keratoderm incision, you have to enlarge that incision. Enlarge the incision
2.8.
2.8. 2.8,
yeah,
I
yes.
think you cannot correct 0.75 consistently in all cases. Maybe some cases is possible, but consistently not possible. Because the data shows the or 2.5 maximum it can correct 0.5, 0.4 to 0.5. So, yes, in case.
I tell them.
Or
In-
in this case, will you consider OCCI?
That is a OCCI, no?
But with the incision, you cannot correct that much.
So I think with this note we come to an end of the session, and it was a brilliant, because of the interaction of the audience, you all made it wonderful and worth it, and thanks to all of you, and I'll thank all my co-instructors who've been wonderful staying at this late hours, and please stay with us for just a photograph please, and thank you everyone.